Thank you, Amy, and it is a real pleasure to be here in this fantastic new facility. Not only has ECMO Retrieval come a long way in the past 10 years, but the whole ambulance retrieval infrastructure has come a long way as well. It has been 10 years since our first retrieval, and it's really timely, I guess, just to look at sort of the progress we've made in that period. So I'm going to start with a couple of case presentations that I think probably demonstrate some of the early difficulties that we encountered with the program. 2007, Easter, I was actually out of town that day, which is probably a good thing because this is the first attempted retrieval, ECMO retrieval. It was a young woman with pneumonia. So they tried to move her conventionally. She became hypoxic as soon as she was put on the transport ventilator, and they called for an ECMO retrieval. We had been talking about doing it for some time, but this was the first time we'd ever had a proper go at it. So a 6-person retrieval team went up from Prince Alfred Hospital. The retrieval team, doctor and paramedic, thought, well, the ECMO team's on the way, so that we're not needed anymore, so they left. And the ECMO team didn't realize that the retrieval team had left, and so they were scratching around trying to find transport ventilators and so on. So clearly there was a lot of misunderstanding between both the ECMO team and the retrieval team as to what their respective roles should be. A few months later, we had another crack at this. This was a farmer from Tamworth who, despite the best efforts of a very good intensivist up there, Chris Trithui, was quite hypoxic and hypercarbic despite maximal ventilation, draining of pleural effusion and so on, and had been hypoxic for about 12 hours before the retrieval team arrived. So Michael Wilson, one of our cardiac surgeons, and I flew up there by air ambulance. And at that stage, we could not transport patients by air in the States, so we got up there fairly quickly. It's about 5 hours by road, due north of Sydney, of course. And we put this patient on femoral veno-venous ECMO, which you'll hear more about later during the course of the day. But this is for respiratory support. That's Michael Wilson there. And there's me in the background with a very military-style haircut doing a transthoracic echo on this patient. We didn't have a tow available. The ambulance service then provided us, actually this was the sort of mess that we were left with. This is basically the old pumps that we used to use. This is the old Rotoflow pump that came straight out of the cardiac operating theatre. So this is equipment that wasn't specially made for ECMO work or retrieval work. So straight out of a cardiac operating theatre, there's the oxygenators down there, there's the pumps here, there's the hand cranks over there. It's just a catastrophe trying to move this patient anywhere, let alone across the state. The ambulance service provided us with their finest vehicle for this purpose. This is the old fat truck vehicle. Some of you probably remember this vehicle. And we bumped our way down the highway, which took some time. So this took us about 5-6 hours in the back of the fat truck. There wasn't enough room for the surgeon and perfusionists that we took at the time. They had to return by commercial flight the next day, a very grumpy surgeon, and the whole process from where to go took about 20 hours. So clearly some things needed to be improved to make this a sustainable program. So the components that really had to be addressed were we had to make a set of decisions regarding what the indications were for ECMO retrieval, what the equipment requirements are going to be, who was going to go on these retrievals, what the logistics of it were, who was going to fund it, and a whole bunch of things that had to be addressed over the course of several years. And I think one of the key steps in that whole process was that in 2007, the ambulance service set up a working party to discuss the logistics of ECMO retrieval in New South Wales, and this had comprised paramedics and doctors from the road arm of the ambulance service, the helicopter arm, the air ambulance, and medical retrieval unit were involved, and a lot of people in this room. Some of the people, Chris Wilkinson was involved with this process, Paul Koenig, Brian Burns, Carol Harbig, the whole bunch of people that were involved in this process that took a lot of time and a lot of effort to get through all the regulatory processes, through all the CASA processes, through all the OH&S processes to make it actually a sustainable and viable service in the long term. So it really has been a huge collaborative effort over the past decade. So these are the indications that have been sent out to all the intensive care units in the state. On the left-hand side are the indications for respiratory support. Basically, if you have a patient that's maximally ventilated, that's has got a low PF ratio, that's hypoxic despite maximal ventilation, that's had reversible causes of respiratory dysfunction addressed, so they've had pleural effusions drained, but remains hypoxic or hypercarbic for more than a couple of hours. That should trigger a call to the medical retrieval unit, and the medical retrieval unit then notifies the on-call hospital as to this patient, and then a discussion can be had regarding the potential appropriateness of ECMO support. On the right-hand side is the cardiac indications for ECMO support. Basically, if you've got a patient that's in cardiogenic shock that's potentially reversible, or if the patient is a transplant candidate, they are possible ECMO candidates. So the whole point of this flowchart really is to start a dialogue between the referring and the retrieving hospitals so that we get early notification of patients that might be ECMO candidates. We don't obviously accept everybody that fulfills this pathway, but we would like to hear about them as soon as possible. So in terms of the actual model of the team that goes and sorts out these patients, there are really two components to that. There's an ECMO team which comprises usually either 2 or 3 people, either a surgeon or an intensivist, cardiac anaesthetist, plus or minus a perfusion technician. And there's a retrieval team, which is the paramedic and the retrieval doctor. And that team structure has worked pretty well in that we often send the ECMO team first to the patient if the timing issues are critical, and then the retrieval team can come along after an hour or 2 or so later once the patient has been established on ECMO. In 2008, we had a formal agreement between Prince Alfred Hospital and St Vincent's Hospital to be the 2 receiving centres for ECMO referrals in the state. And I think if you know anything about the history of Prince Alfred Hospital and St Vincent's Hospital, this is really probably the only example of any kind of collaboration between those two institutions ever. And it's still working, which is, I think, saying something about the people involved with this process. Another big breakthrough was May 2009, the Department of Health agreed to fund both the capital expenses of setting up all the equipment, purchase of cardio-help pumps, fitting out of all the helicopter restraints and so on, and to fund an ongoing commitment to 10 ECMO retrievals per year. So having done all that work, the feeling was that when we're ready to go, ready to open shop around about sort of June 2009, and I was thinking that nothing was going to happen. We're going to be sitting on our hands for the next year or so. It's going to be a complete embarrassment because there will be no demand for the service. But things changed. As it happened, this happened right before the onset of the swine flu pandemic in 2009. So having budgeted for 10 retrievals per year, we basically blew that out in about 2 months because we're charging around all over the state. Did about 24 retrievals that winter overall. All over the state and interstate as well, as far north as Townsville, for patients with swine flu. So generally younger patients that had very severe respiratory failure. And these patients formed the basis of what actually turned out to be a very important paper in the Journal of the American Medical Association, because the flu season hit Australia and New Zealand before it hit the Northern Hemisphere and America. So they were intensely interested in our experience with ECMO support for influenza, and the results were very good. Around 79% of patients of the 68 cases that were collected in Australia and New Zealand survived to discharge, and just over half of those patients were retrieved on ECMO support. So this really, I think, was a massive step forward in terms of the credibility of ECMO support for respiratory failure. But it also, I think, very quickly validated the approach of transferring patients that could not otherwise be safely transported on ECMO support. So it provided a lot of high-level support to the regions and to the smaller base hospitals and so on. Around the same time, again, there was a real confluence of both technical advances and infrastructure advances. We took delivery of the first lot of CardioHelp pumps. We've got 3 of these ECMO pumps at Prince Alfred Hospital, and I think St Vincent's have got 3 as well. You'll have a chance to look at this in a bit more detail. There's one right down there, but basically this is the oxygenator here. Remember the earlier slide I showed you where the bits components all over the place. This is an integrated system. There's a pump is actually incorporated here, drives blood through the oxygenator here. This console here has got about a 4 or 5 hour battery life, and it's got a whole bunch of integrated sensors that include pressures and flows, hematocrit and temperature. So a very, very sophisticated piece of equipment, and has really transformed the whole process of ECMO retrieval, made it a lot easier to move patients around on ECMO support. So one of the real challenges for this whole process was actually getting all the equipment to work in the different platforms that we have to move people around on, and making sure that that could be done safely and as efficiently as possible. So this is the footplate that goes into the helicopter stretcher, and it's purpose-built for restraining the ECMO, the CardioHelp pump. It's made, manufactured out at Narellan by Total Aerospace Solutions, I think, is that right? And it's a very neat, very elegant system that allows the patient to be moved on block without threatening the tubing and so on that's going in and out of the patient. So it's a very, very simple but very, very effective way to restrain these patients. This is the CardioHelp pump in action in a patient somewhere or other, I forget. But you can see how it sits quite neatly at the foot of the stretcher there. There's Claire, who's maybe here a bit later. This is the CardioHelp pump, again being moved around the same footplate in and out of the air ambulance on the lifting arm. So what used to be a very, very labour-intensive, very awkward, very difficult process can now almost be done with one hand with this winching system in the air ambulance. Sometimes the best solutions are the simplest ones, and this is a very compliant, apparently it complies with all the crash testing, 10G this way and that way or whatever. System. So this is the CardioHelp pump restrained on the forward cart of the Sprinter ambulance. These are purpose-built straps, but they do the job and work very well. We've also established an ECMO referral service to New Caledonia. New Caledonia sends their citizens that need cardiac surgery, oncology and neurosurgery and so on. Any advanced sort of support gets sent to Sydney for further management. So we've also established an ECMO program for them, and we've retrieved about 18 to date New Caledonians with this service. So you can really go anywhere nowadays with the right kind of equipment. This is a plane we used to take. It's a bit small, and we've moved to a larger plane, a Falcon jet that's a bit more roomy and comfortable. These bags were also developed locally, CASA approved. These are the bags we take, 4 bags we take for ECMO retrievals. Again, getting all this stuff through all the regulatory authorities and complying and all the rest of it with CASA regulations took a long time, but now that it's actually embedded in the system, I think that we've got a very robust, very durable and very effective retrieval system in place now. So we've just recently looked at our 10-year experience, and this is actually as of February of 2016. We're actually now over 200 cases as of this winter. But our survival rates are still very good. Overall, the respiratory survival rate is around 72%. But surprisingly, for the cardiac cases, which normally are a very tough group of patients, their survival has also been gratifyingly quite high at around 60%. So the overall survival is roughly 2/3 for all comers, which, given the fact that these patients are the 6 people in the state, I think these results are actually very good and hold up very well compared to international standards. In terms of the breakdown of how we move people around, most people come out of the Sydney Basin, and so, as you'd expect, most of them are done by road. fixed wing around about a third of cases, helicopters about 15%. Mostly Sydney and regional New South Wales. Interstate hopefully becoming less frequent because Queensland are finally getting their act together in terms of getting their own retrieval service established, but they still don't have an aeromedical capacity yet. And as I mentioned, the internationals are all to New Caledonia. I want to finish with one more case that again I think probably demonstrates what can be done. And this was actually with ECMO support. This was really one of the real poster childs, I think, for ECMO support. This was a 17-year-old from Brisbane who at that time did not have vena-venous ECMO support back in 2009. This is the very first aeromedical retrieval that was done in New South Wales. And this girl had been on a ventilator for 2 weeks and had terrible air leaks, and lungs were basically falling apart, and she was becoming unsupportable. Again, we're trying to jam this IV pole and all this equipment inside this tiny little jet here. It was a complete, horror show with the old Rotoflow style pumps. But she had a very tough time in our intensive care. Spent about 3 weeks with us. Had a lot of problems with bleeding from chest drains. Was off heparin for a couple of weeks in total. Required 3 thoracotomies over about as many days for chest tube bleeding. Eventually it became apparent that the lungs weren't going to recover, so she was transferred to St Vincent's Hospital, where she eventually spent another couple of weeks on ECMO support there. Underwent a double lung transplant, which was a complete bloodbath, bled about 60 units of blood, factor 7, and had to go from vena-venous ECMO to veno-arterial ECMO because of right heart failure, and then her lungs got reperfusion injury, had to go back on VV ECMO. And to date, she's the longest ECMO run that we've done in Sydney, although now I was hearing about a case at a conference recently in the Gold Coast where they had a survivor who spent 600 days on ECMO in the US, which is just astonishing, and actually recovered. So this woman spent 52 days on ECMO, and here she is after 5 months of intensive care. Went back to her law studies in Queensland, very, very frail, but did incredibly well. And I think this is really a testament to the work of a lot of people, and she had fantastic nursing care and intensive care staff. She had, was very well managed during the entire process that she was with in our health system, and I think the success of this program really has been a testament to a lot of different people, and I think the results are now speaking for themselves. Thank you.